All right. Distinguished policymakers, senior officials, partners in health security, researchers, students, caregivers, and everyone, welcome to Chip Talk Africa. Today's Chip Talk Africa titled One Health on the Front Lines, Breaking Cycle of Lassa virus. Please, can we unmute? Can we mute ourselves? Thank you. One Health is so wonderful hearing the voices of kids. So the title of today's talk, One Health on the Front Line, Breaking the Cycle of Lassa fever, a virus, while eyeing the Hantavirus threat. So as we gather tonight on this 26th of May, 2026, our continent stands at a critical public health crossroads. For decades, we have focused our energy on containing familiar viral enemies within our borders, but public health security is dynamic, and the pathogens do not respect borders, boundaries, or single disease strategies. So while we continue to battle the heavy, recurring seasonal toll of the Lassa virus across West Africa, we cannot afford to look away from emerging and quiet biosecurity threats. The shadow of hantavirus, historically silent in our region, but persistently circulating within our ecosystems, demands our proactive surveillance, unified research, and multi-sectoral vigilance. This is not a time for panic, but it is a time for foresight. Diseases do not wait for us to be ready, and true frontline readiness means anticipating the next threat before it becomes the next crisis. Once again, good evening, everyone, and welcome to this May edition of Chip Talk Africa on the 26th of May, 2026. As many of you know, Chip Talk Africa is a monthly dialogue we began middle of last year to confront pressing public health issues within the premise of the CHIP mission. CHIP stands for the C, community, the H, health, the E, enhancement, A, aid, P, project, community health enhancement aid project. Our vision is simple: resilient, healthy communities across Africa. Our mission is to promote One Health, empower local actors, and tackle zoonosis, poverty, and climate threats. CHIP is an initiative of the War Against Rabies Foundation, WARF, a charitable organization I founded and registered with the Corporate Affairs Commission Nigeria since 2017. Now, through this platform, we host highly engaging conversations with Africa's most knowledgeable, influential, active, and relevant scientists and policymakers. To date, we have brought together experts from Namibia, Tanzania, Ghana, Sierra Leone, and Nigeria. Our audience is global, and while this program is young, it is growing very rapidly. As a reminder, we know that it is said prevention is cheap compared to cheaper than cure, and actually that's where the cheap originated from. Today's conversation is a call to heightened vigilance and integrated action. To truly break these cycles of transmission, we cannot work in isolation. We must bridge the gap between human medicine, veterinary science, and environmental health. That is the true spirit and essence of the One Health approach. So tonight, we say frontline defense requires foresight. We are privileged to bring together an exceptional panel of frontline experts and leaders who live this battle every day to guide us through this dual threat landscape. We will be hearing from Professor Stephen Abba from the Federal University of Health Sciences, Otukpo And he is also the president of the Society for Public Health Physicians of Nigeria. And then we're going to be hearing also from Dr. Yetunde Abioye. She is the National Incident Manager for the Lassa fever and the lead of the One Health Coordination Unit in the NCDC. We're going to hear more from her bio later. Our special research spotlight is on Dr. Rimfa Amos. He's a principal research officer at the NVRI, and a dedicated PhD Hantavirus researcher. So, steering our dialogue for today, I am glad to inform you that we'll be hearing the sweet voices of our excellent moderators, Are Susan Chelston Bako from the University of Buea, WARF, Cameroon. She is a veterinary student, and also Dr. Emmanuel O. Onoja from the WARF, Nigeria. I ask all of us, all our panelists, participants, advocates, and policymakers to please engage tonight with honesty, foresight, and bold thinking. The time to fortify our front lines is now. So welcome to the conversation where we break old cycles and build new defenses. Welcome to Chip Talk Africa. Without further ado, it is my pleasure to hand over the virtual floor to my excellent moderators to officially kick off tonight's presentations and discussions. Thank you all for joining so early, and let's have an impactful session this evening. Thank you very much.
All right. Thank you so much, ma'am, for that wonderful introduction. Good evening, everybody, and welcome to the latest edition of Chip Talk Africa. All right. We are here to have one of our speakers on the call, so we'll proceed to receive our second speaker, Dr. Yetunde from the NCDC. I would like to request that we pay attention keenly as we listen to our bio. Hello, we can't hear the bio being played.
Yeah, I was wondering if it was just me that couldn't hear.
No, I can't hear it as well.
Okay.
Sir, can you start it again? We can't hear. The mic is muted.
Yes, if he can put on his mic, that will be fine.
So that's it. If somebody doesn't want to buy you,
25 US Fellow of the Mandela Washington Fellowship, MWF, and currently on the Plow Right One Health Mentoring Scheme. She has led and supported multiple One Health initiatives, including joint risk assessments and the operationalization of One Health structures at sub-national, national, regional, and global levels as a passionate veterinary doctor. She currently serves as the National Incident Manager for Lassa fever and lead of the One Health Coordination Unit at the Nigeria Center for Disease Control and Prevention, NCDC. At NCDC, she supports the design, implementation, monitoring, and evaluation of national preparedness, readiness, and response strategies using a One Health approach to endemic diseases, emerging and re-emerging diseases with pandemic potential, and other One Health threats. Her professional journey spans various roles within a 10-year progressive experience in clinical practice, surveillance and epidemiology, zoonotic diseases, antimicrobial resistance, food safety issues, food security, public health, health security and One Health initiatives, policy and multi-sectoral partnerships. She has field experience in outbreak investigation and control, joint risk assessment, international health regulations, 2005, implementation, monitoring/evaluation, policy development, human-centered design and community-led interventions in line with the global health security agenda. Dr. Abioye holds a Doctor of Veterinary Medicine, DVM, from the University of Nigeria and a Master of Science in Public Health from Anglia Ruskin University, UK. She has also completed professional training in pandemic preparedness from the London School of Hygiene and Tropical Medicine. Additionally, she has certificates in leadership, in public management and professional training, in theory and principles in transboundary disease risk communication, engagement, TDRCCE, using a One Health approach from Wayne State University, US, and AFRO, UN Academy respectively. Known for her collaborative spirit and results-driven approach, Dr. Yetunde is deeply committed to community-led initiatives and inspiring the next generation of public health leaders. Outside of work, she enjoys watching movies, traveling, and exploring the role of storytelling in policy making/implementation.
Thank you so much. Dr. Yetunde, you're welcome. You have the floor, ma'am.
Thank you so much for that wonderful introduction. And thank you so much for having me. So just a quick, I have actually been giving, just a very brief presentation. And I'm really glad to actually be here with a diverse group of community sharing this update. So thank you so much for everything. And I also look forward to engaging with you just after the presentation. So it's a very short presentation, but the focus we're looking at here is operational response to Lassa fever outbreaks. So Lassa fever is an endemic disease in Nigeria. It's a viral hemorrhagic fever. It's caused by the Lassa virus, which is an old world arena virus. As at Epi Week 20, in the country, we have recorded over 5,000 suspected cases, over 800 confirmed cases across 23 states and 108 local government areas. Unfortunately, we have also recorded 206 deaths, and this leaves us the case fatality rate among confirmed cases at 25.2, which is quite high. Way back in I think this was 2014, we had actually been able to record a CFR of 16%, which is leading us to where we want to be as a country. The goal is actually, the national goal for Lassa fever is to have a less than 10% case fatality rate and even set a new target. If you also look at the far right, or the far left rather, you see a 5-year trend that shows us, outbreaks of Lassa fever nationally from the January 1st to 31st of December of the last 5 years. So from 2022 till date, And could see for the one with the highest peak in Epi Week 3, that was recorded in 2023, followed by like in 2024, where we had a peak in Epi Week 9. And for this year, we kind of seem to have had our highest peak at Epi Week 7, which is between, just somewhere around February. We have 52 epi weeks. That's what we use in our epi calendars, and these are updated and aligned annually for us to be able to report. So we report in epi weeks, and our epi weeks run from Mondays to Sundays. So just giving you this is just an overview of the situation. So it's our problem. It's a problem that's largely within the West African region, but then Nigeria bears the highest burden, unfortunately. So it's 4% of cases are constantly recorded. Like for this particular outbreak, we've been recording that from 5 states, so Ondo, Bauchi, Taraba, Edo, and Benue states. And then we also have the predominant age group affected are people within the ages of 21 to 30 years old. And the virus has, no specific affinity for male or female. So male and female are almost equally affected when you look at the ratio. So what we've been able to do this current outbreak, like we always have preparedness, because it's an endemic disease. If you look at the line graph at the far left again, you see that there's no period where we don't have a confirmed case of Lassa fever. The only thing is just that we have peak periods, and then we have periods whereby we have low levels of transmission. And even for this year, we are seeing a slightly higher number of cases at this time than we usually see during this period of the year. This time, we expect we should be completely out of the emergency phase and then be preparing for the next outbreak. So we're hoping within a couple of weeks, we will be out of this particular outbreak. So most times, the peak is usually from January to April. So we usually have after action reviews, which we like Winston Churchill would say, never allow a good outbreak go to waste. So we want to document lessons to see what went well, what went less well, not looking at a particular fault finding mission, but actually trying to see how we can improve our response and preparedness and readiness to the next outbreak, which is just unfortunately around the corner. So there are several activities, but these are just some of the highlights where we had activated an incident management system, of the Emergency Operations Center for this particular outbreak. So that was activated at level 2. The after action review also informed some of the decisions in preparing for this particular outbreak. We also deployed national rapid response teams to 7 states out of I think we had then about 10 states, but then we had 7 priority states where we had rapid response teams deployed using a One Health approach. We also did consistently have regular emergency operation centers within which we have every week. There are also high-level advocacy visits that we've had. The DG of NCDC actually participated in one of these, and of course continues to provide offsite support to all the states. We distribute medical countermeasures, and we also strengthen our laboratory network. We share diagnostic test kits, and we also assess and optimize them as on a needs basis. And of course, continuous collaboration across states. So this just shows, a bit of what we have. So the epi curve of the cases so far, where you could see where we have a rise in the number of cases and deaths. So like I said, we've had unfortunately over 200 deaths recorded so far, and that's huge. Our case fatality rate has not been this high in the last, I would say, there about 5 years. It's really quite high right now, and we're doing all we can to see how we can reduce that. But then, unfortunately, this is the current situation. So this just shows basically just the number of cases per week. The other one that had showed the line graph was looking at within a 5 years period. Why this is specific, as at the current epi week that we have going to be reporting. This has not actually been published, but it will be published before the end of the week. But currently, we are currently in epi week 22. Just for those that would like to know, we're currently in epi week 22. Epi week 21 ended on Sunday. So we'll currently be getting updates nationally from the states on their Epi 21 CTREP, and this is Epi Week 22 currently. So this just also shows, looking at the map of Nigeria. So there's no state in Nigeria that has not recorded a suspected case of Lassa fever for this particular outbreak. But then you could see the distribution of where we have confirmed cases. So those that have recorded at least one confirmed case are in green, while the other one in the brown have negative cases. And then the big bulb also just shows you, or the bigger bulb or the red bulb just shows, the range of the number of cases, whereby the smaller one, you have 1 to 33, and then a slightly bigger one, 34 to 127. And then the biggest ones were like the 5 hotspot states. Well, not all of them, but some of them, right? You can see Ondo, you can see Bauchi that have recorded, over 100 and, within that 126 to 218 at the moment. Then by the right just shows attack rates based on population, and some of the high burden LGAs that we currently know is Owo, we have Toro in Bauchi, we have Esako West and the likes. So just coming down to the main discussion of this presentation. So that's just setting the scene and just trying to let us know what we see nationally. This is the incident management structure that we use. I use the One Health approach in Nigeria. So at the National Emergency Operations Center, we have the incident manager, we have a liaison officer. This is quite similar to what we have, even though for now, I know the structure we have has deputy incident manager, which basically most times serve to lead the coordination pillar, which are majorly around the liaison aspect. We have a surveillance and epidemiology pillar. We have a case management and psychosocial support pillar. We also have a laboratory pillar, infection prevention and control and safe burial. We have risk communication, community engagement, and infodemic management pillar. We have the logistics pillar, we have research, we have vector control and environmental sanitation, and we have food safety. And this uses a One Health approach. So we have colleagues from the Federal Ministry of Agriculture and food security as part of the food safety pillar. We have our colleagues from Federal Ministry of Health as part of the food safety pillar. We also have colleagues from Federal Ministry of Livestock Development as part of that pillar. For the vector control and environmental sanitation, we have colleagues from Federal Ministry of Environment, and this in its sense, these are the national, but at the state level, they also have this level of very similar structures that cover coordination, logistics, finance, and all of that. So that's also clearly at the various states. So especially with states that are very endemic for Lassa fever, they also conduct the dynamic risk assessments that informs the activation of the incident management system of the Emergency Operations Center. For the research pillar as well, this cuts across, Federal Ministry of Livestock Development, Federal Ministry of Health, Federal Ministry of, Federal Ministry of Agriculture and Food Security, so many of these other pillars as well, the Nigeria Centers for Disease Control and Prevention, and even subnational states. So it depends on the level of research they're doing. Now we have a lot of research around vaccine development, but then there are also a lot of operational researches that are done once teams are also deployed. We also have FELTIP residents, which are part of the Nigerian Field Epidemiology and Laboratory Training Program. As part of this research, they are being deployed to the teams to also support, operational research and see how we can also better improve or make sure that we don't waste any outbreak lessons. So just trying to show you what we do, and this incorporates, the elements of One Health approach. We know that Lassa fever is an endemic disease. Primary source of infection is from rodents to humans, but we have very well sustained and established human to human transmissions. And as shown previously, you could see we have reports of cases all year round, but then it's a low level transmission, right? And then we also have, unfortunately, 45 healthcare worker infections that has been as at this particular epi week. So we are hoping that in recent years, a lot of, we'll have more operational researches that will be able to, strengthen the One Health approach and targeted more around pandemic preparedness, right? Targeted more around prevention, readiness, most times, unfortunately, a lot of funding is released for response and not for the prevention or preparedness aspect. Because when we have our after action reviews, there are wonderful recommendations, but it seems like this is not just a Nigerian problem, by the way, it's a global problem. You have situations whereby, there's just a rapid move from there's just a rapid move from trying to respond once the outbreak is declared over, and then we continue and go back to routine. For us, we don't actually rest on our ORs anyways. We usually have bi-weekly meetings following the deactivation to whether alert mode or if we are in watch mode, depending on the mood that we are at the emergency operations center. We really don't go to rest, and that's why we are always making sure that we collaborate across the state, implementing high impact activities that don't require a lot of funding. We are always very creative. In fact, since I became the incident manager, we haven't had a lot of resources. We've just been making sure that we are very creative, and we are dedicated to this, right? We are very passionate about the work we do, and also making sure that we continue to push, building on the shoulders of the giants that have gone ahead of us. I mean, the Emergency Operations Center was established for Lassa fever nationally in 2017, and since then, a lot of efforts have gone into making sure that our operations are sustained. And from one incident manager to the other, I'm the fourth incident manager so far, and it's been a great pleasure leading the team to do this. So together, we'll continue to see how we can reduce the case fatality rate of Lassa fever to less than 10% and see how we can set up a new target. Thank you so much for listening. I look forward to engaging with every one of you. Hello. Please confirm that you can hear me. I hope I haven't been talking to myself.
We can
No,
hear you. Thank you.
doctor.
All right. Thank you so much.
Thank you so much, Dr. Yetunde, for this valuable insights and knowledge you have given to us. And I got to learn a lot. Thank you so much. Okay, without wasting much of our time, I will introduce to us a special research spotlighter by name Dr. Rimfa Amos. Please let's pay keen attention as his digital bio is being played.
Hello? Hello, are you hearing me?
Yes, we can
Dr.
get
Rimfa
you.
Amos Gambo is a Principal Veterinary Research Officer at the National Veterinary Research Institute and a wildlife veterinarian with research interests in wildlife pathogens, zoonotic diseases, molecular epidemiology, and One Health. He is passionate about investigating pathogen-host interactions in wildlife to strengthen disease surveillance, public health preparedness, and biodiversity conservation. He is currently pursuing a PhD focused on hantaviruses in rodents and humans.
Welcome, Dr. Amos. Please, the floor is all yours.
Okay. Actually, my slides are with the with you. Can you share the slides? Very good. I want to thank Dr. Yetunde for her presentation. She has talked about a few things that I will also talk about on this presentation. I have to prepare these slides because hantaviruses are still new pathogens in Nigeria. No work has been done so far in rodents, except in 1986, Professor Tomori did a little work in his postdoc, where he collected, sera from Ibadan, Jos, that's from Jude, to Japan. And the serology he did, he was able to get some reaction to hantaviruses in Jude here in Jos. in fact, just happened to give him more results. So that necessitated me to go into investigation in rodents, and also to do another serology in humans to find out if we still have some reactions to hantaviruses in them. So by title, hantavirus is an emerging global challenge. At least we are all aware of the very recent panic that the world went into because of some experience where hantaviruses were able to kill about 3 people, and some are still hospitalized. So I want to talk a little bit about it. Well, I want to thank you for the introduction. Thank you so much. Actually, hantaviruses are a group of enveloped RNA viruses belonging to the family Hantaviridae in the order Bonavirus and genus Hantavirus. These viruses are named as such because of where the virus was detected in South Korea. Many UN soldiers have died around that period of time, and then the research was done and it was detected. The virus was detected around Hantavirus River and named as such. Hantaviruses are the causative agents of 2 major zoonotic syndromes, hemorrhagic fever with renal syndrome, which is largely found in Europe, Asia, and Africa. The milder form of HFRS is nephropathia epidemica. And then we have another syndrome which is largely from North Central and South America, which is called hantavirus pulmonary syndrome. By way of introducing the primary zoonotic transmission, this virus is largely transmitted between rodents. That is the horizontal transmission. And then between rodents and human, we have that's the vertical transmission. Human to human transmission. There are actually no human to human transmission in most of the hantaviruses, with the exception of the Andes virus, which recently caused some panic. The Andes virus is the only known hantavirus capable of spreading from human to human. It requires actually very close face-to-face contact among family members, just like the spread of tuberculosis, which is a family disease. Hantavirus too can be spread, among family members, sex partners, or friends, close friends, associates. And then also in the hospital environment, hantavirus can spread among healthcare givers. The route of infection is aerosol or direct contact with respiratory secretions like saliva and so on. Human to human transmission is highest during the early febrile stages of hantavirus. That's in human. Hantavirus is very stable in the environment compared to other RNA viruses. They are very stable. For example, hantavirus can be as stable as between 10 to 15 days in urine, droppings, and nesting materials at room temperature. Hantavirus too can be very stable in frozen environment and also in temperate region. Hantavirus can be so stable as far as for weeks and even months. Hantavirus can still be very stable. But under a very heavy heat condition for about 30 minutes, because this is an RNA virus with a lipid layer within 60 degrees centigrade, this lipid layer can degrade. making hantavirus ineffective. So high temperature can cause hantavirus to be ineffective. So exposure to direct sunlight too can denature, can kill hantaviruses. Geographically, hantaviruses pose a very high risk in dry, arid climates because dry air allows the infectious material to spread easily. And also, this is a map showing the pathogenic spread of, the distribution of pathogenic hantaviruses. I will not waste time, but you can see in Canada, North America, Central America, you can see Synombri virus. And the Synombri virus is the virus that is transmitted from human, to human. Andes virus. That's not Synombri, please. Andes virus is the one that is transmitted from human to human. As you can see, look at the tail area of, South America. You can see between Chile and Argentina. That is where the virus is isolated. And if you go to the next graph, that is hantaviruses actually are spread by rodents, and these rodents are classified as New World and Old World rodents. So the green color there is showing area where the New World rodents are, and actually hantaviruses are host specific. So each rodent has a particular type of hantavirus that it harbors. So if you look at North America, Canada, South America, they are harbored by the rodents. They are harbored New World hantaviruses. So if you look at Europe, Asia, and part of Africa, these are where Old World rodents are found, and they have different hantaviruses that they spread. So hantaviruses are also, research work has also been going on in Africa, and the only place where research work has not been done in rodents and largely on human beings is Nigeria. As you can see, Nigeria's population is so high, but this virus has not been worked upon. And the reservoir is also the same as Lassa fever too. What I mean is, it is not necessarily multi-mammoth rodents that spread, hantaviruses. We have hantaviruses in all other rodents too. For example, the brown rat and the black rat, also mus musculus, which are mice. And then we also have hantaviruses also in shrews. But this work has not been done in Nigeria, considering how much work has been done in Lassa fever. Work needs also to be done in hantaviruses. So if you look at that map, if you look at Guinea, there is a virus there called Sangaso virus. This virus is very closely, is a hantavirus, but is very closely related to one of the ones that cause a lot of disease in Europe, which is called Dobrava virus, and is there in Guinea. But the problem, the good thing here in Africa, let me not say is the problem, is that though hantaviruses have been found in their reservoirs, but no clinical case in humans maybe has been detected, or maybe because research work has not been going on there. So I cannot tell for now. So this is the recent case that happened in the cruise ship that was largely publicized in media. One concern to me is the potential source of this Andes virus. the first point there is pre-boarding environmental exposure in endemic area. Over here, it could be possible those victims actually were exposed to Andes virus before they boarded the ship, the cruise ship. It's either they were exposed to the pathogen directly from rodents or from human to human transmission before boarding the ship. And then the onboard environmental exposure, it could be possible that here, this the rodents that is a carrier of this virus may likely have gained entry into this cruise ship and then find its way to contaminate food items in the ship where these human beings were exposed to. So it could be possible that that was also another means of transportation, or those that may likely have gotten the virus before boarding were able to share this virus due to close contact between people. And so, though this is the end of my presentation, but I just want to say that there is currently no treatment for hantavirus, except if the condition is detected very early, especially the history of the condition. If it is really open up, then there is that possibility that the patient may likely have been exposed to hantavirus, because the early sign is the same with malaria. It's also the same with Lassa fever. So we need to get detailed history to be able to focus on hantavirus, because from the work that I have done, it may interest you to know, it has not been published yet, but there are lots of serological reaction to hantavirus in humans here in Jos. So when it is published, the information will be circulated. And finally, I want to thank my research professors who are still patiently waiting for this work to be completed. Professor Caleb Kwidi, who is the chairman of the supervisory team, Professor Paul Abdul, who is retired, Professor Grace Kerr, and Dr. Luca Pam. So I want to thank you for listening. Maybe you can go through the slides yourself because of the time limit. Thank you.
Thank you so much for that insightful and thought-provoking presentation, Dr. Rimfa Amos. We are very grateful. Thank you so much. As we build momentum on that tonight, we want to transition quickly into question and answer sessions. And therefore, request that if you have any questions, please send them to the chat box, and also do well to indicate which of the speakers you're directing your questions to. All right, I will proceed to ask the first question we have here, and this question is directed to Dr. Yetunde Abioye. Right, one of the participants is asking, ma'am, are there factors that have been identified to cause the peak of Lassa fever observed between January and April in Nigeria?
All right, thank you so much for that wonderful presentation, Prof. It's really great to see that there is a work on hantavirus here in Nigeria, not just one, but and for yours as well, looking at especially our special geography. So heading into the question that was asked, there are factors actually. So what we've noticed is, those periods are usually the dry seasons. And when you have this, during the dry season, you have an increase, in rodents and human interaction, whereby they live, there is no food in the farm, right? The place is dry and they're looking for food. So there is that tendency for them to come into people's houses and interact more, right? Even though we know that there is a low level transmission of, the virus all year round, but peak transmission periods have been recorded within the dry season. So that's I don't know if I should take the second question. That's the key factor for that. There's another question here, with regards to the
All right,
CFR.
you can go ahead. You can.
Okay, thank
All
you
right,
so
go
much.
ahead, ma'am.
Yes. So yes, we know that a lot of VHFs could have CFR up to 100%, but globally, CFR for Lassa fever has been recorded at approximately 1%. And most of the cases like this CFR we are recording right now is among confirmed cases of Lassa fever. And I remember talking about the 2024 where we had our CFR to about 16%, which was a very good spot. And we're hoping to continue to have a decline because the goal is to have a less than 10% case fatality rate for Lassa fever. Unfortunately, it seems, it has been rising over the years. And even this year is quite high compared to what we've been having. So some of the things that have been really contributing to this, um, if you remember in 2024, we had this global funding cuts that has affected a lot of these surveillance activities, generally across, the world, especially, in resource limited settings where, like Nigeria, where you don't have a lot of funding to support that. So those issues are actually contributing, whereby you have late presentation of the cases and you have, unfortunately, deaths. We also have, issues around the jackpot syndrome as well, whereby a lot of the people that have been trained, that have experience in managing these cases have also left the country. So that has also left a huge gap. Currently, we've been doing a series of training, but we know that it's not enough. And even currently, a lot of people are not even, most people prefer to read IT or something, just a very short course, maybe even nursing to go abroad and practice rather than even thinking of staying in the country to practice, or even a lot of the ones that get to finish here also plan to go abroad, and we clearly understand these gaps. So there are gaps in when it comes to surveillance, there are gaps when it comes to case management, there are gaps when it comes to risk communication and community engagement efforts as well. But just to also say that based on research, we know that about 20% of cases that come in contact with the virus become symptomatic. Not everyone comes down with Lassa fever. And inside this 20%, they are the ones that we see being hospitalized, right? Coming to the hospital, cases whereby they've been treating, they have fever, they've been treating it with either antibiotics or anti-malaria, and it hasn't responded. And then, most times, even most people on this call, once they feel feverish, they will not first of all go to the hospital, say they're running a test. They'll start self-medication before even going to maybe a local chemist, and then from there going to a hospital to run tests. So those are the things that really, build up to increasing this case fatality. We might feel like, oh, but this disease has been around, or it's been, the virus has been named since 1969. Even before that, there were characteristics, but why do we still have these issues? It shows that, there's still a huge lack of awareness, even in places where it is endemic. You have issues whereby people will say it's an anger of the gods. You have, people just come up with a lot of stories, a lot of things happen. And even when it comes to the safe burial, even what we are seeing with Ebola, whereby a treatment center was burned down, all of that, issues like that still happen as well, even though not as violent as that. But sometimes, even in the process of burial, people get more infection just because of poor risk communication and community engagement. So there are quite a lot of issues. I think I'll stop here. I could go on and on and on because this is my area, but I think I'll stop here. These are the two questions I saw as well. Thank you, Anova.
Thank you so much, Dr. Yetunde, for clarifying us on this. I think my next question is directed to you again, Dr. Yetunde. Please, what practical or community level interventions remain most effective in reducing rodent to human transmission in high burden states?
Yes, so for this particular one, we always prefer, the case of whereby you see people. I mean, this happens, right? We are in Nigeria here, we're talking heart to heart, whereby you have an overhead bridge being built and people still cross the express or the highway without using the overhead bridge. So the most important thing that we'll say that we've seen that works in communities, community-led interventions, whereby the community is part or even leading the creation of strategies to these problems, like trying to explain to them that this disease, this is what happened, right? And how can they come together to solve this problem? So a lot of times the interventions you might want to bring from the West are not applicable locally here. So we've seen some researches, even though this is not sustainable, right? And when you look at it, it's just some pockets of research, but we know that it's possible, right? It requires an all of community, all of society approach, whereby communities are at the center of these designs. So the human is at the center, right? This is the problem that we have. These are some of the risk factors that we see. How can you, better prevent yourself from getting this infection? And those are the things we have seen, whether it's around food storage, whether it's around risk communication and community engagement, whether it's around safe burial practices, whereby the imams are taught, right? Whereby the community is led to know that it's not like we don't want you to see your loved one, but these are the risks involved. So most times, having someone in that community, right? We've had cases whereby, like for example, in a settlement, in a rural settlement, whereby they move around and all of that. We've had cases whereby, unfortunately, like the parents died, or the husband died, the wife died, the child was infected, her uncle was infected. They were able to, like, once the signs and symptoms started, relating to that, they quickly went to a treatment center, having confirmed the diseased people, as being positive for this, and they saw the same signs. Now that person went to the treatment center, came back alive, and is now like, Akweriga Karfi, do you have vaccine for this? Right? That person is now the one becoming an ambassador in that community for this. So most times when you have survivors being at the face of leading this, we had a situation whereby a governor of a state, right, was once affected. Like, I think either his niece or his one of the family member died from Lassa fever, and then he too got infected but survived. That governor donated a treatment center in that state. That governor also became a champion. So these are the things. It needs to be community led. It needs to be community centered. It needs to be human centered. We cannot go and start imposing, do this and do that. It might not be practical. They have their cultures. They have their norms. You have to make sure that it's contextual. What is working in the north will not work in the south, will not work in the east. Right? What is working in the west will also be different from what will work in the north. So these are issues that it has to be contextual. And even you see, even in states whereby you have an endemic LGA and another non-endemic LGA, there are different factors as well. The rats basically are actually abundant. In fact, to interest you, the multi-mammate rat, Mastomys natalensis, is named after a river in South Africa. So this rat is actually abundant in the whole of Africa. It's not just in West Africa or in Nigeria. The rats are abundant, and there are also other rodents that can transmit. There are other non-rodents, right? Domestic animals have also been found with antibodies. So there's quite a lot of work in the field when it comes to this. Sorry, I quickly saw a question around healthcare worker infection. I just want to quickly also talk about that, the issues with regards to rising healthcare worker infection. Unfortunately, this particular outbreak has had a very high healthcare worker infection. And most times, even when you look at the history of Lassa fever, it was result of the healthcare worker infection that the sample was taken, missionary nurses, sample was taken to the US Center for Disease Control and now Prevention, right? And then was isolated and found to be a new arena virus, and then was named after Lassa town. So, but then, even after that, we've been having recurrent, healthcare worker infection. That even in one of the meetings we had, Professor Tomori even mentioned dates, right? That were very, for me, it was very, I don't know how to call it. Is it nostalgic or how to say? And for us, it really breaks our heart that we are still having to discuss this. Sometimes you feel that healthcare workers, that have been trained should even know more about this virus, but you still see poor IPC, right? Some of them, in a bid to the passion to save life, they even go in there with their bare hands sometimes, right? Under that pressure and all of that. We've had issues in treatment centers whereby they even use torchlights. Well, we are Nigerians, we know these things, to conduct surgery surgery and do a lot of things. So in some places, even when they are trained, they don't have these resource materials. They don't have elbow length gloves where they can use to palpate, and for pregnant women, which sometimes are mostly implicated in these cases. So the O&G section, whereby a woman comes with bleeding and then there's an urgency to do a C-section and all of that to save her and the baby. And then, unfortunately, sometimes turns out to be, a Lassa fever, infection. So, aspects of training, of course, continuous professional development is very important. The aspects around whereby you mentorship, aspects around whereby the facility itself is also not doing what it's supposed to do, right? Routine monitoring and evaluation and all of that, preparedness, readiness, healthcare facility level, is also a major factor that we're seeing. So, it's really a comorbidity of factors that we're beginning to see, and it's also showing that there's a breakdown, in some of the routine practices have not been sustained, whether due to a discontinuation of some programs. Because what we are seeing is that, there's this thing like the way we are discussing about the rodents, and, they could transmit hantavirus, they could transmit, different other disease, whether it's mpox and all of that, right? If you are able to control Lassa fever, you are also able to control a lot of other viral hemorrhagic fevers and even some other endemic diseases when it comes to whether environmental sanitation, healthcare waste, many other things. So these are just some of the things that we have seen in the field, and sadly, we've even lost some healthcare workers, and these are our colleagues. Every life is very important to say. No life that has been lost, out of the 206, like these are people with dreams, these are people with vision, right? These are people, consultants, people that's just regular people like you and me. So people with dreams, people with vision, somebody's father, a caregiver, so a lot of things, and we really recognize that they're not just statistics. Okay, so I see a question on how can one who is infected be cared for. I don't know if I should answer that, or I should just type in the chat
Hello,
box
ma'am.
to take more than.
Yeah.
Yeah.
Okay, thank you so much. We would like to take a question for Dr. Rimfa, and then we'll
All right,
come back to you.
over.
All right, thank you so much for your scholarly acumen. We are so excited to have you on this subject matter today. Thank you, ma'am. So my next question will go to Dr. Rimfa. Please, we want to encourage every participant that the floor is still open. You can ask your question in the chat box and they will be responded to accordingly. All right, so Dr. Rimfa, my next question is to you, sir. We previously believed Lassa virus was restricted only to masculine natalensis, as Dr. Yetunde has also mentioned because of our delivery. But recent field studies implicate other species like masculine erythrolyphus and the African wood mouse. Sir, does your research or other researches indicate that these same alternative hosts are also capable of carrying and shedding the hantavirus?
I didn't get your question.
Okay, so my question is, does your research that these alternative hosts, that's the mastomys, erythrolyphus, and the African wood mouse, are capable of carrying and shedding hantaviruses?
Yes, it could be possible, but currently research work is still going. It has not been identified yet, but it's a possibility that apart from Lassa fever, multi-mammoth rodents can also carry Lassa fever. Even though from my work which I did, I actually collected a few multi-mammoth rats, but out of the number that I collected, none was positive for hantaviruses. But I will not doubt it because Avicantis, this rat, grass rat, I least expect that I was going to find hantavirus in that species of rat. But surprisingly, from my work, I was able to detect hantavirus from that grass rat called Avicantis nileticus. So, everything is possible. Am I understood? Hello, sir.
Yes, yes, sir. Yes, sir. I can hear. Yes, I can hear
I
you
said,
audibly. Go ahead, sir.
everything is possible, but at the moment, there is no research work that has been done using rat to hunt for hantaviruses. This is the first work that has been done so far. So, but you never can tell whether multi-mammate rats, but you know that in African wood mouse, Sangaso virus has been detected, which is a hantavirus that is closely related to the Dobrava virus in Europe. And that Dobrava virus it has been linked to one of the agents that cause, hemorrhagic fever with renal syndrome, which is a very deadly disease. So I cannot say one will not find hantavirus in multi-mammate or any other rat. At the moment, we have brown rats in Nigeria. So brown rat has been found to carry hantavirus in Europe. No one can tell. It could be possible they have the antivirus in Nigeria as well. And even the black rat, that's the roof rat, the black one that we commonly see invading our homes. Hantavirus has been detected in those black rats as well. So we must have to be very, very careful. Just as we guide ourselves against Lassa fever by controlling rodents, we must also take the same, step in controlling those rodents against hantaviruses. This is equally a very deadly disease because you can see that there are a lot of dialysis centers across the country, So we don't know if at the moment hantavirus is a contributory factor. That's why this work is being done, even though in a very limited area, but immediately after this, the work can be expanded to cover many other states. Thank you, sir.
Okay, thank you so much, Doc. Our next question is going to be directed to Dr. Yetunde. I can see in the chat box, the question goes, how can one who is infected be cared for?
All right, thank you so much. So, we have treatment centers, designated treatment centers across the country. But then even from primary to secondary healthcare facilities and even some tertiary, right, that might not be treating, they also know how to properly refer patients. So once, there's a confirmation and someone is infected in maybe epidemiologically linked, right? Immediately, there is that proper referral, right, through the right channels. State Ministry of Health will guide, how that person will be properly transported to the treatment center for proper care. So, unfortunately, treatments, most times early presentation, like we say, it's very, very important. Once the person presents early, there's also no cure for this. But then we have supportive therapy whereby we use ribavirin and some other supportive care based on the symptoms that is being presented, because Lassa fever can present like malaria, it can present like a bacterial infection. It presents as many things. And in late stages, unfortunately, there are bleedings from different orifices, a viral hemorrhagic fever. So it's very important that the person presents early. And that's why, as much as possible, we also try to educate the public, even though we know that, more efforts need to be done. We usually bolster these efforts around the peak seasons, but then there's also every, throughout the year, we also communicate. But, there are several outbreaks that are occurring at the same time that could also be in the news more than setting at a particular time. So that's I don't know if that's answers a bit more. And you can also check our NCDC websites for our situation report, just to also get updates. You could also dial 6232, which is also our emergency contact number, and then immediately you could be referred to the right channels depending on where you are in Nigeria.
All right, thank you. Thank you so very much, Dr. Yetunde. We are most grateful for your valuable insight. Thank you, ma'am. Our next question goes to Dr. Rimfa Amos. Sir, in the course of your presentation, you said the hantavirus presents early signs that are similar to malaria and Lassa fever. So the question is the screening for hantavirus available nationally? That presently speaking, given that clinicians have seen illnesses looking like the hantavirus, but since it is not routinely tested, there's no basis to say that what we are dealing with is a hantavirus exposure. So, are there screening that are available currently for hantavirus?
Are there what?
Is the screening for hantavirus available
Okay.
nationally? Presently
Okay.
yes.
Yeah, actually, for now, there is no clinical case of hantavirus in any of our hospitals. Even though serology showed that human beings are reacting to the presence of the antigens, because since there are no clinical cases on ground, actually there are no screening centers. With time, if this, I'm not praying for it, but if it does occur that people are being screened to have, at the moment there is a colleague in the hospital, that's why this work is One Health. At the moment there is a colleague in Jude we are working together with. He will take further, screening in Jude. Maybe a wider screening involving people with kidney problems. So if we are able to detect hantavirus in patients suffering from kidney problems, if we detect hantavirus and that will also necessitate, carrying out screening exercise following the Lassa fever pattern, because we will not have to construct hantavirus screening centers. We will follow the same line with Lassa fever because the disease is spread by rodents. So there is currently no screening center because the disease has not been detected in humans yet. This is like the first kind of work to try to find out if human beings react to the antigen. I don't know if I'm clear.
Very clear, sir. Thank you.
Thank you so much, Dr. Amos, for this exceptional answer to the question. Our next question will be directed to Dr. Yetunde. Please, with the War Against Rabies representatives from both Nigeria and Cameroon present here tonight, and we know pathogens ignore political borders, as they all say, disease anywhere is disease everywhere. Please, how can our two countries build a real-time epidemiological data sharing network to catch cross-border zoonotic transmissions early?
All right, thank you so much. But this question is really above my pay grade. So it's a question that it's really needed. I mean, there are conversations at the global or regional level within ECOWAS, but I'm not the DG of NCDC, and it will be difficult to make any bold statement. Nor am I even the director of surveillance in NCDC. But of course, collaborations among scientists exist. Collaborations amongst institutions, bilateral agreements also exist. Collaboration amongst, yes, within the IHR, so the International Health Regulation is also, I know Cameroon is a signatory to that, Nigeria is a signatory to that, and it will be, it's kind of surprising to see that, especially like, even though Nigeria is very endemic and we have the over 90% of cases that are recorded, right? Other countries might not be searching for it as much as, or I don't have a lot of capacity like we have, right? We've taken this as something that we need to do and fight, as much as possible. You'll be also, there are rarely, in fact, if hardly any, most of the exports that we've seen within the West African regions, other parts, are actually to Europe, the US. You hardly even see, like even Cameroon is not endemic for Lassa fever. And you have a very endemic state, Taraba, that shares border, with Cameroon. So just trying to say basically that, of course, there are so many international, laws, policies that guide, information sharing of surveillance, data, collaboration, and all of that. But then this is beyond something that I could really say, but I don't know what interests, the Cameroonians might really have on any research on here, but of course, a welcome collaboration, within this forum, of course, is highly, highly welcomed. Yeah, thank you.
All right. Thank you so much, Dr. Yetunde and Dr. Rimfa. Such a delight to have you on this conversation tonight. Thank you very much. Shortly, I will be handing over the digital floor to our very own CEO and the convener of Chief Talk Africa. She's an exceptional leader. And we will testify that Chief Talk Africa has been a transformative event for every one of us. So I'll be handing over the digital mic to Prof. Grace Kia as she takes us further in tonight's conversation. Over to you, ma'am.
So good evening once again, everyone. Thank you so much for your rapt attention. I saw very unique participants in tonight's meeting, and we're very grateful for your presence. Persons such as Dr. Polycarp Sampson, Dr. Nana, University of Professor Nana, University of Maiduguri, a number of you guys that made it. I mean, made your presence available for us today. We're so grateful for your participation. Thank you so much, Dr. Yetunde, for your time. Thank you for coming in early and starting with us early. Thank you so much for bearing with, the slight delay in the start off. And thank you so much for the information you have downloaded. I'm happy to see a number of my students on the call because I'm the one that normally teaches them the Lassa fever, hemorrhagic fevers generally in the faculty. And so I'm sure they're excited to have heard and learned so much from you tonight. So thank you so much. And Dr. Rimfa, thank you for doing your best to make this presentation within the short period of time that you were given to present. And so note that for everybody that is present here, remember that this is like a tantalizer, like an appetizer, right? So it pushes you to want to go and learn more. Like I tell my students, the internet is there for you to go study, learn. I mean, there is so much to learn about this hantaviruses. We have the new world, we have the old world hantavirus. What is it about? Why the new world and why the old world? Where are this new world and where the old world? Okay, so what is the difference? Which one causes the hemorrhagic? There is so much that Dr. Rimfa has presented and so much for us to go and learn so that we can establish in our knowledge bank all that we need to know concerning hantavirus, not because we just want to gather knowledge, but we're preparing ourselves. Peradventure, there is an outbreak somewhere that we find ourselves. It might not be in Nigeria. You might find yourself maybe in another country, maybe in China. China, they have the old world hantavirus, with the hemorrhagic syndrome. Or you could find yourself in Russia. They also have that. Or probably in Northern America, in the Americas, it could be the northern part of America, the Americas, or the southern or central. They have the pulmonary hantavirus. So you need to get yourself abreast with information and prepared. Know how to prevent this and know what to do when there is an outbreak. Our communities need us. Our families need us. We need each other. So I pray that this particular presentation for today will not be one that we'll just go and shelve, but we'll go back and listen to it again. It will be on the YouTube by tomorrow afternoon. Around this time, it should be on the YouTube. You can go back and listen to it once again, and also go back and study about it on the internet, and learn some more. Thank you so much for being around here to be part of this. And I also want to say that I want to appreciate those people that have been contributing to make sure that we are able to float this Chip Talk Africa every month. We have the H-Medic, the vet medics, and the Happy, Healthy Animal, Healthy People Initiative, who have been given support so that our students can be able to attend this meeting and also be able to be supported, for their data to be supported, So we thank those organizations for their assistance. And there's also some individuals that have been giving. I just want to thank everyone that has given money to help us with what we're doing in our communities, vaccination of children that are being beaten by dogs from poor families, helping us to do a lot of programs in communities. Thanks to all the volunteers of the War Against Rabies Foundation, the Cheap Talk, the Cheap outreaches that we have been doing in schools and communities. Thank you. You heard from Dr. Abioye Yetunde. You heard how she said the community. We have to get the community to be able to drive their own prevention activities. And how do they get to even know how to drive their own activities? We need to go and train them with what we know, and then see them adapt it, modify it to their own communities, and make it relevant to their communities so that they can be able to drive it. So each and every one of us, we're so important in the fight against whatever infectious disease. We're so important. Please, let's go into work together and make sure that we are not taken unawares by any health crisis, so that we don't end up having any pandemic like the COVID or Ebola. We've been hearing about the Ebola, what's happening in other countries. So thank God for NCDC. They are getting ready so that nothing takes us unawares, and so that it doesn't penetrate our country. And we also have a part in it. So thank you so much, Dr. Yetunde, Dr. Rimfa, for presenting. I'm sure Professor Abba would have loved to be here. Something must have come up. And I know that we'll get to know what happened, because he was excited to be part of this meeting. Truly, he was excited, especially because of a publication that he published recently, where they did a multi-state community surveys, and they have beautiful findings from it. So if you have time, please make time and study. We could send, we'll try and send out to all the emails his paper so that you can take time and study the publication and enrich yourself. And let's all get prepared for to make sure that our communities are safe. Thank you so much once again for the presentation. And I look forward to seeing you in our next Chief Talk Africa come June. June is going to be great. So look forward to our meeting. Thank you, guys. Thank you, my beautiful moderator, my beautiful moderator student, Dr. Susan. And thank you, Dr. Emmanuel, for wonderful moderation. You guys were great. Thank you. Thank you, everyone, and do have a great holiday. And for our Muslim brothers and sisters, enjoy a great big Salah. And don't forget also, send us our little pieces of meat. God bless you all, and we love you all. Take care. See you next time. Thank you.
Okay, thank you, ma'am.